Hey there, it's Marisa, and I'm thrilled to have you join Heidi and me for an incredible conversation with the remarkable Katherine Gutteridge. Katherine's expertise as a trained nurse, midwife, and psychotherapist specialising in childbirth trauma brings a unique perspective to our discussion. In this episode, Katherine dives deep into debunking myths surrounding childbirth trauma, offering invaluable insights into what we can all do differently. Together, we explore self-reflection, challenge societal norms, and discuss actionable steps to create a more supportive and empowering environment for birthing individuals.
Welcome so much, Katherine, to our podcast. I'm here with Marisa Kamel, and we're really looking forward to discussing your wealth of experience in the maternity realm. So tell us about yourself, Katherine, and what you're up to at the moment.
Right. Okay. Thank you so much for allowing me to come on here, first of all, and to talk about being a midwife, mostly. So I've been a midwife since back in the 80s. So that's quite a long time. And I'm both a nurse and a midwife, but also much later on, I did a master's degree in psychotherapy. So I'm a clinical psychotherapist too. I love midwifery. I love the work that I've done, and I suppose my career was always about being with women. And I always felt that was the most important thing for me, that women were happy, listened to, and advocated for. So those qualities were always what I put in my head in whatever I did. So I had a long career in the community, firstly, where I mostly did home births or domino births. And a domino birth is where you know your midwife in the community. She does your antenatal care for you. When you go into labour, she comes to see you, and she with you decides where's best for you to have your baby. And this is why lots of women chose to stay at home. But we had a very small GP unit, which had quite a nice setup for women like that to come in and give birth. And I was probably one of the first midwives there to do water births with them. So I'm talking way back in the late 80s, early 90s. And then after I'd trained as a clinical psychotherapist, it really made me passionate about wanting to listen to women, but also to help direct them into what can make a difference for them in their pregnancies and birth. So I became a consultant midwife, one of the very first in the country, and that was at Leicester, and I helped set up a midwife-led unit there, and that was successful, still going today. And then after about 4 or 5 years, I was invited to take a job in Birmingham, central Birmingham, to a unit that was failing. And so I took the challenge on, and I developed and designed midwife-led services there, but particularly two birth centres, Serenity Birth Centre and Halcyon. And they were massively successful. In fact, we won several awards for those. And then in 2019, I retired clinically because I was appointed as the president of the Royal College of Midwives. And that tenure ended in 2022. And I am retired now, but I'm still teaching clinically. I'm associate professor of midwifery at a couple of universities. And I pretty much do what I enjoy, which is talking about midwifery and childbirth. And I've been all over the world to do that. So I've been very fortunate, and I wouldn't have had it any other way. So that's kind of a bit of a professional update.
I think Thank you. Just to interject there, um, first of all, we're honoured to have you on. You've got such a wealth of experience. But even with all that, I think you missed something. Don't you have one or two books?
Oh, I do. Yeah. So I was asked to write a book, first of all, because although I had all this knowledge and you just get on with it, I find women are pretty much like that, never having the time to put it all down. But I was asked to write a book on understanding anxiety. But I wanted it to be a bit more than that. So I wanted it to be anxiety, worry, but then probably the most severe end of that spectrum being fear. And at the time, I was doing a PhD into that area. And so basically, I wrote up quite a bit of what I knew, but also what I learned in doing some more research. So Springer published the book for me, and I asked a few other people to contribute. So that was helpful. And I've got a book with the publishers at the moment, just waiting to be birthed, if you like, which is around maternity care and survivors of sexual abuse. And this is an area I'm passionate about because it's not spoken about. And I've done a huge amount of teaching on this subject matter. And it's very, very important, I think, because it's so secretive, that we give it our time and support.
So what are the current challenges at the moment that you're finding out in the field in regards to fear and anxiety around pregnancy and childbirth?
I mean, there's an absolute, I suppose, drive now to understand the psychological elements of childbearing, not the psychiatric. This is a psychological. So these women are often unknown. They are just like me and you guys. They're having normal lives, but when they become pregnant, for some reason, the anxiety and the worry escalates. Now, some of that is maternity's fault. And this is what I found in my research, because I thought, well, women have access today to so much more information. So they should be, by that equation, they should be less worried. But no, that's part of the problem, in a sense, because the internet gives us access to absolutely everything. But what I found when I interviewed obstetricians and interviewed midwives and independent midwives, because they're a group of clinicians who see almost exclusively these women, it's the structure of the information giving. So when a doctor talks to someone, they're time poor. They don't have half an hour to sit and talk to someone. So they give that information out very clinically, very much as it's written on NICE guidance or, professional guidance. And women don't always understand that. So an example would be, and this is way back in my career, I remember this happening, a woman was referred in to have a scan because they couldn't see all the parameters on the first scan. This was around about 22 weeks. So she was invited back. The clinician who did the scan couldn't visualize completely the left leg. So she told the woman, I can't see the left leg, and did everything else. And the woman was paralyzed with terror. So she came home straight to the surgery where she was registered, of where I was a midwife, and was in incomprehensive, really, with her fear that her baby was being born without a leg. Now, when I rang and spoke to the sonographer, she told me that she couldn't do the measurements clearly on the left leg. But she didn't say that. And so these conversations are acted out countrywide, worldwide, even, that we give so much information, but we don't step back and talk in a way that is compassionate, reassuring, and also reducing anxiety, because we could do that so easily, yet we don't. So those elements, I think, are really, really important. And it's something that our profession has to work on and has to have much more skill in doing the session with the woman or the appointment, but to be reassuring in nature, but still giving that information.
Absolutely. Language and context is just so important. We've actually got a page on our website about how to talk to women in the right context, because it's so important that women are given certain information to empower them.
Yeah.
But at the same time, like you say, not to cause any unnecessary fear or anxiety. But obviously, I do appreciate that time constraints are a real issue at the moment, aren't they? But getting that language right is just paramount.
Yeah, it is. And I would often have students with me, or medical students, or in some cases visiting consultants from other countries. And it wasn't that I was showing them how to speak to women. What I was showing them was how not to harm women. And I think some of us are really, really good at this. And I know that psychotherapy taught me about the listening, but it also taught me about the speaking. And one of the issues around maternity today is it's an absolute cauldron of potential harm. And that's not because people in there want to hurt women, but it's because they are busy, they are understaffed, they're often underfunded, and the systems that are set up are not meeting the requirements of anyone, either clinician or women. And if we address that, then I think we would release an awful lot of potential and have much happier families at the end of it, but also staff that come to work. So I think the funders and the system directors have to look at their services and have to take responsibility for the harm that's being put into women's lives.
Yeah, because I guess even the kind of the most emotionally intelligent of people, with that kind of cauldron of what's going on, it's kind of up against you, isn't it? So it's a constant, I guess, every conversation, a reset of how am I framing this? Have I listened?
Yeah.
Have I responded in a way that's not going to be misunderstood? And the is the patient the right word at that stage? I would say client in my world.
No, I would say woman, and I know that's controversial, but I've spent a lifetime saying that because I've cared for women. So yeah, it's controversial, but I still hold on to it.
Oh, I like that, and it also personifies the person, doesn't it? Okay. I'd like to just delve a little bit deep on that. So we've spent quite a lot of time talking about the fear. What advice would you give to women to help overcome that fear?
Well, firstly, I think it's find an advocate. Now, that advocate might be her own midwife. It might be someone she connects with early in that pregnancy. The other thing I would say is seek that advocate early on, because harm is cumulative, and anxiety and worry and then becomes fear. That was why I wanted that spectrum to talk about, because being anxious is normal to some degree in pregnancy and mothering. There's not one of us that can say that we had, throughout our period of childbearing and then mothering, we've not had an anxious day or an anxious night, because we have. And that's normal. That's because we need that so that we become more alert, more aware, more receptive. When it's worry, it then becomes ruminative. And what I mean by that is we focus on it more than we don't. So then we become more almost like obsessed about that particular thing. So for that example, that woman then was obsessed with every time she was sent for an examination or a test that she understood everything about it. And that's okay, but the harm was done. And this is why I think having an advocate early on might just take you off that ultimate pathway of being fearful for the whole of pregnancy and then birth, because we know that constant stress and anxiety produces stress hormones, which, many years ago researchers found had an impact on the baby developing, that it might not reach its target weight that it could have in pregnancy. So if we can do all we can to reduce that anxiety, then we have every chance of having, the baby that should be, and the mother who can be a mother without all the trappings of worry. Because if we don't deal with it in pregnancy, it manifests itself afterwards in many, many ways. And some of those become psychiatric in the nature. And that is terrible. It's terrible that we should be seeing someone all the way through, and then in 18 months following the birth of her baby, she's had to have, intensive psychiatric input. And we should be avoiding those situations by supporting women very early on. So advocates can be a doula, they can be a best friend even, but they can be someone that woman has confidence in, but also who knows that woman and knows what is right for her and can speak to her at times where she can't. So I've always pushed women to get someone with them who they can trust, even if that were me, and that I did a birthing plan with her and I was at the birth, even if I wasn't the lead clinician at the birth. So that's the biggest piece of advice I can give. I can also say, don't watch childbirth stuff on TV because it's highly edited. Try not to read your feeds on social media, because once you see something awful, then it just piles it through. And focus on a positive role model in some sense, where someone has had a birth like you want, and use that as the template for your birth. So that's the kind of advice. I also don't forget that this baby is part of a family. So I try to understand what that family dynamic is. If it is that the mother, and this is the research that I found too in my own PhD, if the mother was, her mother I mean, overly anxious, never had another child, and she was aware as a little one growing up that her mother talked about the birth often, that is so detrimental in terms of how that child then becomes a young person, then becomes a potential mother. that can have a massive impact on her understanding of what birth is. So I like to understand the family dynamic, and that was something I did in my clinic. I did a family history, and I tried to pick out the birthing elements within that family as well.
That is so interesting. I'm just thinking of all the different scenarios now of when people can have fear of pregnancy. It could be that they've had a previous loss. It could be what you've just described, their family dynamics.
Yeah.
It could be that they've suffered birth trauma before, or it could just be that it's their first pregnancy and they're really scared of
Yeah.
giving in general. We launched a rainbow pregnancy helpline. And actually, we've just opened it up to midwives as well, because we, identify that they must be sort of very anxious during their pregnancy, because
Yeah.
they have all sorts of things that, all the different complications that can happen. But I'm just thinking, because we're probably going to open it up to everybody actually that's generally concerned and anxious during their pregnancy, to give that sort of extra counselling. But I'm just thinking, we haven't had any calls yet from dads and partners. So, and I think it's very, important that they get the right support as well.
Yeah.
And they also know how to support mum that's going through this fear and anxiety. What can they do to help support their partner?
So this I first really came across when I was doing my master's degree, and I set up a group. Well, I invited a group of women to come and talk about their birthing experiences. And there was one woman in that group who had become very, I won't say violent, but her nature had changed a lot since she'd given birth. And it was obvious she wasn't depressed, but she was angry, and she had become physical with her husband sometimes because he didn't understand what she was experiencing or had experienced during the birth. And I asked to meet up with him, and he and her hadn't really talked about the birth together. And this is one of the complete kind of we miss out on this when we go in and do a postnatal visit. We often don't see a partner because the partner's busy, either sorting out the other children, doing the errands, having a nap because they've done a night feed. So we don't see them together. So one of the things I think that's important is for a midwife afterwards to see them together and to have that conversation. How are you? How are you? So it's they're part of the problem, but they can also be part of the solution. One of the other things, and this again, I probably relate back. I was one of the first people to talk about bystander trauma in maternity. Because if your partner's in labour, everything seems okay, and then all of a sudden, as happens, I don't know, the cord's presenting, and that woman is very quickly turned onto a front on all fours, whipped down to theatre, and he's just kind of sat in the chair. One of the things that's really important is someone to be with him. And we used to just all follow the bed and the woman into theatre. Part of the emergency drills training, and one of the things I introduced in ways of working was to have allocated people who were either going to be the midwife to get the baby in theatre, but also who's the midwife or who's the support worker who's with dad, who's there. And if that is addressed, then often their trauma is much lessened, instead of them imagining what the hell is going on and will he have a wife or will he have a lost baby and his partner. So it's identifying it very, very early that they too can become traumatized by being in maternity settings, and having an understanding about when things aren't going right, who's keeping an eye on him. And that's the case wherever the birth setting is, not just in hospital, whether it's at home. And so communicating with both people, I think, is the key. And that should be done in pregnancy, but also during the birth and beyond.
That thank you. That really resonates with me because I carry some birth trauma, but me and my husband, we didn't discuss it for like a few weeks until after the birth, and he actually was in the room for, I don't know, the long period whilst it was, happening for several hours. And then all of a sudden I had to have an emergency C-section. And he said it was like we were in control together, and then all of a sudden you're in a separate room and you're not
Yeah,
allowed to come in whilst they sort the spinal block and everything else. But at that point you're just was scared, and
yeah.
then he just remembers being like behind the door and not being allowed in, and there was just nobody there. So if that was
Mm.
implemented, that would have helped us
You see, that's
tremendously.
interesting, isn't it? Because I had my daughter in 1980, so we're talking long time ago. But right at the point where I was about to birth, and you too, by the sounds of it, your partner's taken away from you. Out they
Mm,
go. Why? And there's no reason why. There was no reason why he couldn't be in the room with you while you had your spinal. It's
mm,
custom and practice. And this is the thing about maternity, what I talk about the system has customized themselves to be highly medicalized. And
mm,
when you are highly medicalized, it gives you authority, and your presence challenges that, and the partner's
mm,
presence challenges that. I've asked anaesthetists many times, um, what is it that a partner can't see? Um, and there's nothing. There is nothing that they do that your partner can't see. So this is about advocacy again, asking and challenging, because you've needed that support, and you don't stop needing it because it's an emergency. You actually need it more. So I challenge all the time systems and services. Just because it's on the menu doesn't mean that's what you're going to eat. You want something off the menu, and that's what we should be thinking, rather than, oh, we can't do that. Why?
mm.
Yeah,
Yeah, it's about individuals being like feeling empowered, isn't it, as
yeah,
well, rather than just go with kind of the precedent or what's been.
yeah,
And something else that struck a chord actually was just, the discussions afterwards with me and my husband, because I suffered from postnatal depression, but
yeah.
then equally the hormones is just a totally wild ride, and I don't think emotionally I was capable of really discussing with him what had happened.
No.
And now I look back with kind of light and fondness, but it's taken time. But I guess Heidi as well, that's where the rainbow line would come in as well.
Mm,
Yeah, absolutely. And I'm thinking about women that might not have a partner
Mm,
that was able to support them in the first place,
yeah,
or so they might be on their own, or perhaps women who have a partner but they're not very supportive. And I
supportive. Yeah, yeah,
women who've experienced sexual abuse as well, and the
yeah.
fear that they go through giving birth, it must be so much harder for them as well.
It is. It's something, again, I'm really passionate about this because um, personally, it's something I've experienced right from a child, and the connections to how it manifested within me. I didn't learn about really until I became a psychotherapist, and then everything made sense. It's a little bit like in life, you kind of get on with life, but it always felt slightly out of kilter. But once I started to understand what this did to me and that part of me that I can't see, then I felt like all the bits clicked into place. It's something I've taught and presented and written about for years and years now. And to be honest, I don't see the system changing towards that. None of the healthcare providers have it as part of their education. It's usually an ad hoc session that they try to slot in somewhere. And I know that because I've been invited to be the slot in. But if you imagine, and not just me as a woman, as a midwife, as a mother, all the fears and anxieties around that, about being touched, about being made to do things that might not feel right, about worrying what is less of a problem now. But one of the things I worried about constantly was, what's the sex of my baby? What will make me feel more confident or less confident? So those things are less of a surprise today. However, worrying about, can I bear to leave my baby with someone? What are they going to do to my child when I'm not there? So it doesn't just kind of rest on the birthing process. It's, how will I feed my baby? Do I want my baby next to my breast? Those are all questions that I have had discussions with survivors. And that in itself is a life's work, really. But then you've got women who've been raped by strangers. You know, in Birmingham where I worked, we have immigrant populations, but also asylum seekers, refugees. And one woman in particular had her husband and her eldest son murdered in front of her, and then was multiply raped by those soldiers. And now she's having a child. These are all kind of incomprehensible emotional things. And one of the difficulties we have is to respond appropriately when we know that information. And this is the thing that midwives worry about, and also obstetricians worry about. Well, I can't do anything. You can't change what was done, but you can make this moment in time better or appropriate and compassionate and loving in the right way. And that is how you as a leader lead your team. And that is how you as a clinician at least think about the things that you're going to do or want to do, and respect the answers that come with that, because that causes problems. So for instance, I want to examine you and the baby. So this, I'm talking about abdominal palpation. And, you know, you have to think, how pregnant is she? Because if she's 24 weeks, you know, what are you going to do if she says, no, I don't want you to touch my tummy? What's the purpose? What's the outcome you're expecting? So those are questions you have to ask yourself. And if she declines, she declines. And we document it, but we treat her with kindness. There are ways to do those things. So I talk to midwives about, if she's got a very lightweight piece of clothing on, do it over the top. Tell her she doesn't have to be undressed. It is, like I've said, it's the menu approach again, that, oh, we always do it that way. Well, we don't have to. And another clinical intervention that only occurred to me later in my life, that I had difficulty with because I was held down because I was a child, um, was having my blood pressure taken. So that cuff around my arm, I didn't realize, but I was having all those same kind of um, stresses inside of me, completely dissociated. That the cuff tightening up felt like a hand around my arm. So one of the ways I always teach is to say, "Have you had this done before?" Yes. How did you feel? Is it all right if I do it? Are you okay about that? So it's putting the power back across to the woman and not assuming that this is what I have to do and I'm going to do it whatever. These are very subtle skills, but they are the things that make the difference for the whole population, not just that woman. So I
They
practice that on everyone.
they really do. It's bespoke, personalized care, isn't it? I'm
Yeah.
just thinking about training.
Mm.
Is this part of training that student
No,
midwives get in universities? Because I've got a feeling it's not.
no, it isn't. No. And it is something that I try and incorporate into the people that I see, but it should be fundamental right from the start, day one of their training, that we talk to them about this style of care, and really personalizing it. And it might just be the one that you don't, who is the one that is harmed by it. So that's the risk you take. And I would say to all midwives and all clinicians, actually, do you want to be that one person who's a bad memory for that woman? I know I don't. So that's the kind of conversations I have with people.
Feels
So
like some people clearly go through some unthinkable and unimaginable trauma, that most of us thankfully can't relate to.
Mm.
And what you're saying is so relevant, like across any aspect of healthcare, isn't it? And it should
Yeah,
be,
yeah,
and life really, because
yeah,
you never know what you're going to bump into. But obviously, it happens a lot more in healthcare. But just to have that as the foundation,
mm.
to see you as kind of one person impacting so many people, but it's how do we create lots of you to really drive that ripple effect?
Yeah. I think it's one of the reasons I wanted to write the book, um, because within it are those examples, or are those words that always kind of flatten the power dynamic. Because at the end of the day, I I would want to feel that the woman had ultimate control and was advocated for and was not harmed by the system. Um, and what I see at the moment from maternity across the UK is a system that is harming women, not planning to, not setting out to, but by increasing induction rates, by reduction in staffing, by um, almost like unraveling all that the better births and beyond was supposed to. Um, what we've got is a recipe for harm and for fear, and
Mm.
that is unforgivable in my book. And leaders need to really, really take responsibility for what they're doing, because we can't change this.
I know you do work in Scotland as well.
Mm.
What's the differences between Scotland and the UK, and are there things that we could learn from?
Well, one of the things, I was invited by the consultant midwives in Scotland to each of their areas where they work, and I even went up to Stornoway. I did a workshop up there. So one of the senior lecturers up at University of Stirling invited me every year to speak to the students. So in that way, we were addressing the education of people in practice, but we're also addressing students becoming midwives. And then you have to forgive me, I can't remember when this started, but NHS Scotland had some funding to do an education programme. And Mary Ross Davey, who I know as a friend, but also as a clinician, wanted to put together a package of education electronically. So NHS Scotland gave us some funding for that, and I worked with them and some of the midwives and other researchers to put together an education programme online. And that would be for any healthcare professional, but particularly in maternity or gynecological settings, and for care at any age. So obviously over the age of 18, but all the way up to elderly, because elderly women refuse care in just the same way that young women will refuse care. So we did that, and that evaluated very highly. I'm not sure whether it's now the built-in online education that we started it with. It may have been modified in some ways. And I have offered it to NHS England and I offered it to the Royal College of Midwives, but it hasn't been taken up countrywide apart from Scotland. So there's work to do, but I am working with a brilliant midwife lecturer called Elsa Montgomery. She's based in London at King's, and she's worked with the survivor population from a research point of view, and the Survivor Trust, of which I'm a member too. So there's things happening, but it's all based on funding. It's all based on if you're lucky, you get it, and if you're not, you don't. But there's nothing to me more important than having this as part of undergraduate education.
It sounds like throughout the biggest impact in terms of the resources and what is available now is on an individual basis. So we're responsible for the way that we act, and this is about having a movement and not being dependent on resources. Don't get me wrong, of course, resources and change would make it so much better. But these are things that people can do every day. It's been really helpful for me to hear this perspective and actually just my own reflections of things that I can do differently, and support I can offer, and like properly check in with people, when they're going through, when they're pregnant or after birth.
Yeah, it's not hard.
Yeah, sometimes we get caught in our own stuff, and
We do.
actually you look at the big picture. Sometimes what we worry about is just not. It's just not something. Did you have anything that you wanted to add that we haven't covered, Katherine?
Nothing. I mean, I can't remember where we started from really, but I just would like to say that people listen to podcasts all the time now. I mean, I'm a great podcast listener, and the more we do things like this, the more we reach women, whether that be in the professional setting or the home, the more informed they can be. And it isn't difficult to do these things. It's about prioritizing it as important. And the way, and I can only go on what I've done in my experience, but the way we designed our birth centre was to reduce stress and to reduce fear. The way we practice as a team would have been to identify each other as well as women. So having having ourselves as up here and women down here is part of the problem. I set up a postnatal depression group back in 1995, and I believe it's still running in its format today. And the format was, we as a healthcare professional were there as a woman with those women talking about their feelings. And unless you do that, there's always going to be a divide or a gap or a mountain to climb. And it shouldn't be like that, because many of us as obstetricians and midwives are mothers too. And if we can't talk about how it made us feel, how can we expect women to? So I think I'd like to say that we need to be more like the women we care for, and support them, and not have this like safety only means getting that baby out now. Safety means not hurting me inside so that I can do the job afterwards.
That puts a whole spin on the word personalized care, doesn't it?
Yeah,
Because
it
you
does.
be personal with that woman at the same time, which is so
Yeah.
lovely. So I'm just thinking of places that we can signpost people to if they are feeling very anxious. Obviously, we do have our pregnancy helpline, and we are going to be doing some work on what we've just been talking about language and context and how to give that personalized care. So I'm sure you can get involved with that, Katherine, help us do that. And if anyone else wants to get involved that's, you know, in the NHS and has expertise in that field, we would definitely welcome some help. Is there anywhere else you can think of that women can go?
I mean, there's any number of local services that offer mothers support or information. I think that's the first thing. Whenever I changed jobs, I would always find out what was around that could help women, but would help me too. So it's looking in your local area, first of all, to see what's available. However, today, it may well be that you go online and you can find something that's happening, say up in Stornoway, for instance, and then finding out if there's anything like that near you. In terms of trauma and sexual trauma, the Survivors Trust has got a fantastic website, and I've helped them with the maternity component an awful lot. So there's another online element that women can be helped with. I would say identify what it is you need. If it is anxiety, talk to your midwife first of all, if you can. If she doesn't then appear to be listening, ask if you can see someone else. We get women who click with one particular midwife and doesn't with another, asking all the time. So, and it's a long pregnancy to go through it with someone you don't feel right with. So those conversations, I think, are useful. And I'm always happy to talk to. I take women's requests from me very seriously, and if they do contact me, I speak with them and I hook them up with relevant people. So yeah, I'm not precious about my details being out there at all.
Thank you. We can share those if anyone gets in touch with us. We won't put them out publicly because you never know, but please do get in touch with us on socials and we'll make sure that we direct you to Katherine.
Yeah.
Thank you so much. This has been incredibly insightful, and like I said, I've learned a lot and definitely some things for me to do differently just on my own capacity. But thank you. It's been a pleasure and look forward to speaking again.
Thank you so much, Katherine.
Thank you both for asking me. It's been wonderful. Thank you.
Lovely.